evening, everybody. I am Dr. Soumitra Kumar, Senior Consultant, Obstetrician and Gynecologist of Bhagirathi Neotia Hospital, Rowden Street. So today I'll be talking on recurrent pregnancy loss and which was previously known as the bad obstetric history. So what it means exactly, the recurrent pregnancy loss? In this patient, the patient is becoming pregnant, but the thing is that she is not able to deliver a live birth baby, baby. So the thing is that the full time that the growth and all these things is not taking place properly, and there are three different categories. That the first trimester, second trimester and third trimester. Most of the abortions takes place in the first trimester and the rest in the second trimester. So the first trimester pregnancy loss is mostly related to, that is if we study the genetic study of the product of conceptions, then we will be able to see that 40% of them having chromosomal abnormality. So, in the other hand, if we try to isolate them, and the rest will be, that is 25% will be where the cause is not known, and the rest, that is almost other part, we will be covering, that is the endocrinal problem, that is diabetes, thyroid and all these things, and antiphospholipid syndrome and all obviously it should be diagnosed and treated. And third, obviously genetic problems, that is chromosomal abnormality of patients, that is both the partners, that can result all these problems. And lastly, in the second trimester of pregnancy, this thing happens, that is suddenly we can see that the water can come out and the baby will be delivered or the bleeding starts, and these patients were having cervical incompetence. So for this, the treatment will be the cervical encirclage, and as we know as the McDonald's stitch or Shirodker stitch in these patients. And these stitches are generally given at the late first trimester or second trimester, early second trimester, that is 12 weeks to 14 weeks of pregnancy. And before delivery, we can remove the stitch and the baby will be delivered. The next thing is that immunological factor. The immunological factor is that sometimes what happens that we cannot find out the cause. So in these patients, the immunological antibody that develop, that the killer cells which develops in our body, that goes up, that is the concentration increases and it kills the baby. And in these patients, we often treat the patients with immunoglobulin, though we need to get much more data to substantiate our experience. Next, we will be talking about antiphospholipid syndrome, which is very important nowadays. That is, in these patients, we give low dose aspirin or low molecular weight heparin, and we treat it, and we can get a live birth of a baby. Then we will be coming to the diabetes. Diabetes, we give most of the oral hypoglycemics we cannot use in pregnancy, so we can give injection, some oral hypoglycemics, that is glycomet or something like that, or with it we can use insulin. Next is the genetic problems, that is the chromosomal abnormality. There are translocation, deletions, and the most important, we can say that Robertsonian translocation, that is one of the worst things that happens in chromosomal abnormality, and that results a recurrent miscarriage. That is almost 8 times we will be seeing the miscarriage. And in these patients, obviously we will ask them to go for donor's egg, that is IVF, or we will get, if it is in the husband side problem, then we will go for a bank semen insemination and go for pregnancy. So these are the things. And another thing is that environmental factors. Environmental factor means is that if the patient is exposed to that is smoking, that is the passive smoking. mostly in our country. And if the patient smokes also, that can result to all this problem. Another is that alcohol consumption. Alcohol consumption will obviously have a negative effect in the recurrent pregnancy loss. Now comes the prolactin level. Prolactin in the hyperprolactinemia having a negative effect in the corpus luteum, and in that patients obviously there is a chance of missed abortions or recurrent pregnancy loss. So we got to identify it and treat it. And another thing is important nowadays, that previously we used to do torch test, the toxoplasma, in torch test toxoplasma. Nowadays it is not required because several papers were published that shows that the toxoplasma positive doesn't mean that the patient will be having this recurrent pregnancy loss. So that is not nowadays investigated. And another thing we must understand is the polycystic ovarian disease. PCOD is rampant nowadays. That is a little bit obese patients with acne, hirsutism, and irregular menstruation. This is almost 20% of our patients. We can get this complaint, and we identify them as a diagnosed as a polycystic ovarian disease. In polycystic ovarian disease, if after treatment the patient become pregnant, and we got to give the support, luteal support is important, and without luteal support these patients go for recurrent miscarriages, and that is very important. So you continue this support at least for some time, that is after around 14 to 16 weeks of pregnancy, because this time the corpus luteum and the progesterone will start stop secreting, and ultimately this thing will be taken up by the placenta. So up to 16 weeks, 14-16 weeks, we got to give progesterone support. Next comes the obviously the all the support. Mainly what happens in some of the patients is that the patients not getting enough support from their family, and he got to work very hard in the office and all other working places. So in those patients, obviously we suggest them to take little bit of restful life, which is important, and increase the blood flow of the uterus, and it will nurture the fetus. And all these things works. Obviously the bicornuate uterus and all these things got to be considered, and HSG and laparoscope, hysteroscope, all these can be done, and we got to mend the problems, and then we ask the patients to go for pregnancy. Thank you. Namaskar.